people are joining in, we'll give everybody a couple minutes to um, log on to the webinar and then we'll get started. Okay, so just in the interest of time, I'm going to go ahead and get started. So thank you all for joining in. My name is Joni Guzman, and happy Stroke Month. This is our first Stroke Month webinar, so I just want to say thank you to Sanford Health for volunteering to do this Stroke Month series, Stroke 101, as part of our Mission Lifeline Stroke South Dakota project. So I just want to mention just a little bit about Mission Lifeline Stroke South Dakota. This is a statewide initiative where we are working to close the gaps in the stroke system of care so that your zip code doesn't determine your outcome if you're a stroke patient. So just trying to get patients, excuse me, from A to B as quick as possible and into definitive care. And so as we kick off Stroke Month, I also want to mention that it is Nurses Week and just want to say thank you to all of our nurses for everything that they do. I don't think your job gets easier. I think it gets harder every year, every whatever. So just thank you for everything you do on a daily basis. And welcome to our webinar. One more quick thing before we get started is I just want to share a quick disclaimer here. And it's just that, whoops, let me click down here. All right, just drink this. The opinions expressed in this webinar are solely those of the presenter and may not necessarily reflect the American Heart Association's official positions. This webinar is intended for educational purposes and do not replace independent professional judgment. The American Heart Association does not endorse any product or device. And so with that, I am going to welcome our presenter, Jessie Wolf, who is just a fantastic volunteer for our project. She's a stroke coordinator with Sanford USD in Sioux Falls. So, Jessie, I'm going to pass it over to you to take it away.
Perfect. Thank you so much, Joni, and thank you all for attending and listening in today. I'm going to try to share my screen. Oops. Let me try that again. Sorry. Can you guys see it all okay?
We got it, Jessie.
Thanks, Joni. So again, I am Jessie Wolf. I am a stroke program specialist or stroke coordinator at Sanford USD Medical Center. Today, to talk about stroke in the emergency department. My background, they call my position stroke program specialist. We used to be a stroke coordinator. And talking to Joni's disclaimer too, a lot of my slides are Sanford related, but we do base our policies and procedures off of American Stroke Guidelines. I'm not great at citing those, but those will be kind of mixed in. And then another disclaimer, policies, guidelines, and research is constantly changing in stroke care. A little bit about me. Before I was a stroke coordinator, I was a neuro nurse on our stroke unit for 10 years before. I'm a huge neuro nerd. I learn something every day and I get really excited talking about my position. So I will slur my words and get excited, and too much coffee doesn't help that today. And then we'll go through some case reviews at the end. I've been told clots are icky. I'm obsessed with them, but I'll give you a heads up if you're not into looking at those clots that we see with strokes. Some objectives today, we'll look at an ischemic versus a hemorrhagic pathway in the emergency department, IV thrombolytic therapy, and then successful strategies to decrease thrombolytic door to needle. I have stars kind of spread out throughout the presentation, so look for those red stars when we're talking about successful strategies to decreasing. So did you know stroke is a brain attack? We hear a ton about heart attack, but a stroke is an attack in the brain. It's general knowledge that heart attack is identified easier by the general public, that they know that that pain in their chest could be a heart attack, but a lot of the public is unable to identify symptoms of stroke. Very common diagnosis, about 800,000 new strokes per year, the fifth leading cause of death, and lots of survivors of stroke, 4.7 million stroke survivors in the US. It's the number one cause of long-term disability in the US. So lots of people having strokes then living with that disability. And hypertension is the number one cause of stroke. So just some fun facts. Two types of strokes, ischemic stroke and hemorrhagic stroke. Ischemic stroke caused by a blockage within the brain, blockage caused by a plaque or blood clot. Ischemic stroke shows up about 6 to 8 hours on a CT scan, will show up very much sooner on an MRI scan within 20 minutes or so. And with our ever-changing technology, it feels like those time windows are getting smaller and smaller. And those neuroradiologists and stroke interventionalists that can read those imaging can pick up that very crisply. So ischemic cause is by a embolic source, cardioembolic source, possibly a blood clot from the heart, a large vessel atherosclerosis, small vessel disease, just a blockage within one of those arteries. So you can see in the picture, the pointer is pointing to where that blockage happens. So that's a major artery within the brain. The blockage occurs and then ischemia or tissue damage happens around it. On the right picture, hemorrhagic stroke is caused by bleeding inside or around the brain tissue. When we do CT scans on our strokes, the bleeding will show up immediately on CT. Main cause is uncontrolled hypertension. Oh, it slid forward, sorry. A ruptured aneurysm. One of the classic questions that we've heard with stroke, what comes first? You have a patient that falls in the middle of the night, comes in with blood on the head CT. What came first? Maybe it's a traumatic fall and they hit their head after they fall, or did they have the bleeding and then that caused them to become weak and fall? So what comes first, the fall or the bleed, is much like the chicken and the egg problem. Stroke recognition, how to identify symptoms of stroke. So when we talked about the public not knowing the symptoms of stroke, we really want to pound this out in the public for public education, EMS education, nursing identification. So how to spot a stroke. You see a lot of acronyms. Be fast is a very common one used and captures a lot of those symptoms and easy to remember. B is balance issues. Loss of balance can be accompanied by headache or dizziness. Eyes, blurred vision or loss of vision is a big one. F, when you see one side of the face drooping. A stands for arms, but think arm or leg weakness on half of the body. S is speech difficulty, loss of speech, slurred speech. This can often be times confused with confusion, that the patient seems confused, but they're trying to say words and they can't. And T, time to call for an ambulance, and really promoting that to the public too, calling 911 for any of these stroke symptoms. Prior to hospitalization, prior to that patient getting to the hospital, we can't tell what type of stroke they're having until they have that CT. And that CT is to rule out hemorrhagic stroke immediately. We're going to start first on the ischemic stroke pathway. So CTA, CT angio of head and neck, will oftentimes be done. In our facility, we'll start with a CTA of head and neck. A CTA can test for large vessel disease or a patient that is amenable for having clot retrieval or thrombectomy. So BFAST is stroke recognition. Stroke van is another really useful tool looking for large vessel occlusion. And this is new to a lot of facilities, that we want to use both scales, that we recognize the stroke and then need for thrombectomy as a potential if they're large vessel occlusion. So stroke van. A large vessel within the brain, you can see the skull off to the right here, would be a ICA artery, M1, M2 artery, or basilar artery, are all large vessel occlusions. I kind of teach our staff, when you're looking at a stroke, a large vessel occlusion has a lot of symptoms. It's not a subtle gray, typical, like subjective symptoms. It looks like a stroke. So to do the stroke van, think of the word stroke. does that patient have any focal weaknesses? So weakness in the arm or leg. If they do, that's positive. We move to V. Look at their vision. Do they have gaze deviation, a vision field cut, or double vision or blindness in their eye? A is aphasia, inability to speak or understand speech. And N is neglect, ignoring one side of the body. With that focal weakness, if the VAN, if one of those is positive, they're a positive large vessel occlusion van assessment. So this is indicating that they might be a thrombectomy patient. Some of the research on stroke van assessment, it's got about an 82% success rate in detecting LVOs or large vessel occlusion. And this is great for any hospital, but especially those smaller hospitals that this patient is indeed having a stroke and we need to get them to a hospital that can do thrombectomy, that has interventional capabilities to pull that clot out. And keep in mind, time is brain, time is brain. I know we really talk about that mantra a lot with TNK, but also thinking of those large vessels, the longer that clot sits there, the more damage it causes. When patients arrive in the emergency department, we talk a lot about the last known well and the onset of symptoms. And why is it termed that? It's kind of neurology lingo. We're trying to figure out when the stroke started. If it was an unwitnessed stroke, when were they last known well without stroke symptoms, or when were they last at their baseline? So it's an important piece of the puzzle. And I always kind of get a lot of flack that we really question and really ask that patient some specific questions to find out this. If we know the onset and the last known well, we can expedite that treatment, what treatment's available. So onset, was it witnessed? Was somebody with the patient? It can be unknown if they're alone. And I say we trust our patients, we love our patients, but I always further question that onset. A good example of this, at Sanford, we get a lot of morning stroke codes, 7, 8, 9 o'clock stroke codes. The patient woke up and they noticed their symptoms. Maybe a patient has slurred speech and right arm weakness at 8 o'clock. They let EMS know, I woke up and I had a stroke after I woke up. So we have to kind of dial that down a little bit, ask the patient, what happened at home? Did you speak to anybody before 8 o'clock? Did you use that right arm before 8 o'clock? For example, did you sit up out of bed and try to shut off your alarm clock with that right arm and it wasn't working well? And then you turned over and tried to talk to your spouse in bed and your speech was slurred. And then if that patient's thinking, yep, my arm was weak when I woke up, we ask them, what time did you wake up for the day? Or what time did you go to bed last night? Did this happen last night when you set your alarm? Was that arm working right? Sometimes that patient's like, yep, I sat up on the side of the bed. I went to the bathroom. I came back to go back to bed. And then the arm was weak. So I was woke up without symptoms. Last known well, if that patient is that patient that woke up with those symptoms, did you go to bed at 10 o'clock last night? Was that arm okay? Etc. We will use that last known well time. Both times are important to know. We call those patients that have those strokes before they go to bed wake up strokes. So question time, really peg that time down and then refer that to your provider. This is a great important piece of the puzzle for especially EMS. Sorry, my slide just said you're done on here. We're going to slide forward. So stroke codes, every site is specific to their procedure. Stroke symptoms noted within 24 hours is a Sanford protocol that if any symptoms within 24 hours, we take a look at them. Minions are awesome, all hands on deck. And this is typically what our stroke codes look like. A lot of people excited to help this patient out and probably too many in the room at one time. Accurate onset. So knowing when that patient's symptoms started, give us that window. Can they have a thrombolytic, tenecteplase or alteplase? Within 0 to 4.5 hours of onset is when that stroke started. We can potentially treat them with tenecteplase is what we use. Getting an accurate bed weight immediately. Our patients go straight to CT from EMS and then on a weight bed. So we will have that zeroed and waiting and get that weight right away. Thrombolytics are weight-based. We want to make sure we give them every accurate dose that we can, and we call it liquid gold. You want to give them every little milligram that we can, and make sure that weight base is recorded that they're accurate weight. We have had some patients in the past where maybe they were in the clinic 2 days before and they had a standing scale weight, and then we took the weight in the ER on a cart bed the next day, and it can be off. So get a zeroed cart or however you get your weight, have it zeroed and get an accurate weight that day. CT or CTA of head and neck. Again, we go straight from triage or EMS straight to CT. We say if that patient's able and stable, if they have a stable airway, our emergency department doctor will meet them coming out of EMS, look at their airway, and if they're able to lay flat, we will take them straight to CT. I had a red star up by this because that's a best practice, getting them straight to CT. Guidelines say that we have 20 to 25 minutes to get that CT started, but having more time shouldn't mean waiting. So getting them as soon as you can, making sure they have, oh shoot, I apologize, that keeps sliding forward. Having a large bore IV if you're doing CTAs to make sure we can give contrast dye. A quick neuro in the CT, so getting the patient over onto the CT bed, doing that be fast, a stroke van, grab the story, drill down that last known well, onset of symptoms, and then call family to verify while in CT if needed. Again, best practice, that EMS calling ahead and pre-activating that stroke code, reporting a blood sugar and going straight to CT. I started talking about when we first started straight to CT, if able and stable, it was really a big practice change. And nobody loves change, but having EMS, those two EMS that come in with our patients, typically getting that patient over to the CT, it's extra hands, more to the story. It works out really slick. Use of telestroke services, best practice, a picture's worth 1,000 words. I always say neuro's a little gray when you think about, for example, STEMI. You can look at an EKG and it's black and white. Neuro symptoms can be subjective and can be a little bit gray. So having a specialist look at that patient and see what you're seeing as you're giving a report is a best practice. They just call the stroke code at Sanford. A stroke interventionalist available to read those scans. A lot of sites do have a neuroradiologist or a virtual radiologist reading those scans, calling ahead and pushing those images to have somebody read them as soon as you can. We have 45 minutes, but let's not wait 45 minutes to get a read on those scans. Door to treatment is 60 minutes. With every couple years they're saying, we could do this in 30 to 45 minutes. Why should we wait 60 minutes? And delivering that drug safely, but as soon as we can. In interventional capable centers, we want to make sure that groin puncture to get the clot out is within 60 minutes or less. We'll talk a little bit about TIAs later, but if symptoms completely resolve, we do not activate in my system, but get a hold of those neurologists and let them know that we have a potential TIA, but symptoms have resolved, and then monitoring that patient very closely. If those symptoms reoccur, the clock resets for potential stroke code, potential thrombolytic. A best practice, having that thrombectomy or thrombolytic exclusion at your fingertips. And we say, we are in a digital world, but there's never enough computers around. We have available via EMR, media, and a paper print off so that multiple people can be looking at the inclusion exclusion criteria. We do have walking questions. So when we're quick assessing that patient and talking to EMS or their family, we'll talk about exclusion criteria for thrombolytics. So are you on blood thinners? Are you on Coumadin? And is Coumadin level greater than 1.7? Are they on the newer Coumadins or the DOACs, Pradaxa, Eliquis, Xarelto, etc.? And then additional questions, have they missed a dose? Maybe they're planning a surgical procedure and they have to be off of their Eliquis for so many days. And when was the last dose? Are you taking Plavix, Brilinta, aspirin, any of those DAPT drugs? It's okay to give, but it's good to know that they're on those. And a lot of the patients get confused when we talk about blood thinners. Yes, I'm on aspirin. Aspirin's an antithrombotic, and it's okay to give thrombolytics after. It's not a contraindication, but which blood thinners are you taking? So specifically asking and knowing. some more walking questions. Have you had any recent bleeding, trauma, surgery? What did you have and when? Did you have open heart surgery 2 weeks ago, or did you have a pinky surgery 2 weeks ago? The surgery matters, and then reporting that to the physicians. Do you have any bleeding or platelet disorders history? And then, so after the walking questions are done, we do take out the inclusion, exclusion, and go step by step through every one of them. And then double, triple check the onset, last known well. If we're looking to the pathway to giving TNK, make sure we're doing blood pressure checks on that patient. Make sure the blood pressure is lower than 180 over 105 consistently to give. Technically, it can be slightly higher up to 185 over 110 to give, but it's got to be even Steven 180 over 105 or less. Aggressive management. So if we're needing to give IV push drugs for this, we give two pushes and then we move to like a cardine or a continuous medication. So the example on the left is just an example, but open for use if anybody wants to. So big news, what was it in March? Tenecteplase is finally FDA approved for stroke. So all of us stroke nerds had a big happy dance. But a best practice, knowing that tenecteplase is also a STEMI drug, is to sort them out because the doses are different. So this is an example of what we do here. We have a STEMI kit and a tenecteplase stroke kit, and you can tell the heart and the brain and different colors to, so when you're in a hurry, you know what you're doing. When we give tenecteplase, I'm from a facility where we're super lucky to have such great pharmacy friends that mix it for us. But when there's a million things going on and nursing is mixing, just to have all these safety checks in place. The maximum dose for a stroke is 25 milligrams. Of course, it's higher for cardiac, so that's what makes it confusing and a safety check to make sure we're doing the right dose. So having a separate package, in our package, knowing that we can give a higher dose for STEMI, it's a 10 mil syringe to admin, and then we only have a 5 mil syringe in our stroke bag so that we couldn't accidentally give that patient too much. Having something separate is a best practice, and then having the frequent, the dose calculator, and this is what we have. There's lots of really awesome options out there, but help you with calculations, and a worksheet to help with the calculations and then confirm your calculations. A flush of normal saline and pre and post is recommended. And then a best practice is frequent skills validations for mixing. Even though I'm super spoiled and have pharmacy mix this, and sometimes the same pharmacist has mixed it 50 times this year, just it's nice to go through in a controlled setting and do a skills validation for mixing it. Also, a best practice is knowing where that blood pressure needs to be for what type of stroke coming in. So I'm sidetracking a little bit here. When we talked about ischemic stroke with thrombolytics or TNK, the goal is to be less than 185 to give, maintain less than 180, and then what drugs we're using to maintain that blood pressure. If we allow that blood pressure to be a little willy-nilly high and then treat and then chasing it all day, it can increase the risk of bleeding. Ischemic strokes who are not a thrombolytic candidate, not a thrombectomy candidate, we can allow permissive hypertension. So allow that blood pressure to be higher than normal. Your stroke is causing your blood pressure to be quite high. Just treating 220 over 110 or above. This allows that brain to establish its connections. Sometimes we want to watch for low blood pressure in those patients. On the flip side, hemorrhagic, which we will talk about, typical blood pressure goals. Now my slide's a little dated, 130 to 150 is typical. High potential for drips, knowing that blood pressure is really willy-nilly, and that increased blood pressure can cause that bleeding to increase. So having something, I've seen some sites have a badge card, having this in your order sets, having it somewhere where you can easily reference it is a lifesaver. AI imaging. So I know there's a lot of different AI platforms out there. We do use rapid imaging at Sanford. Viz AI imaging is another awesome imaging platform, but this is helping our physicians. So when our physicians are using on call 24/7. They have a patient come in with a stroke code, and we're using Rapid AI or another platform. That imaging goes straight to their phone, alerts them that imaging is done. It helps read the image, or I say read the imaging or give alerts on the imaging. This is an example of the picture on the upper left of a patient that has low blood flow through that vessel, and then gives you an alert that, hey, look at this right away, something's going on with this patient. And another benefit of platformed imaging is using CT perfusion scans. CT perfusion scan calculates brain penumbra. So a core part of the infarct is what damage has been done. Penumbra is over the next 24 hours, what is that brain going to do with the stroke and how much of that brain tissue is going to be salvageable. There is a lot of research going on right now with CT perfusion scans, when to use, when not to use, what's a large core, what's a small core, and which of these patients you treat. So that will be different. And I heard there's more research coming out in July on this, so more to come. But this is what a slide would look like. You can see the little purple imaging is that patient's core, and the green is what that patient will do in the next 24 hours. Limited MRI is a series that shows acute stroke 2. When we talked about stroke showing up about 20 minutes after onset, it will show up on an MRI. Ultrastat MRI can also look for damage. There is some research out there giving TNK past 24 hours, so up to 24 hours. Definitely still research phase, not standard of care. But a big look at this is that that patient has been having symptoms. Maybe they went to bed at 10 o'clock last night and woke up with lots of stroke symptoms. And for this patient with the MRIs here, the one on the left is showing, this is his ultra limited MRI, showing a small stroke with big symptoms that haven't showed up on FLAIR images or extended images. So this patient probably had a stroke sometime in their sleep, and it's going to be bigger if we re-image them without treating patients. So some of the research is saying this patient would be appropriate for extended window TNK. Clot retrieval or thrombectomy. This is indicated for a patient. The biggest indication is if they have a large vessel occlusion, typically within 24 hours. A big consideration of this is what is their pre-stroke baseline. A lot of physicians will look at pre-stroke baseline and not the patient's age. If a patient is 90 years old and independent, living at home, does their shopping, has family, converses daily, modified Rankin score of a 0, the age isn't as a factor that we see that large vessel, we would take them for thrombectomy. If that patient is 90 years old, unfortunately in a dementia center, wheelchair bound, that would be some consideration and family conversation if this patient is streamlined to intervention. Exclusions is if they do not have a large vessel occlusion. If there's no clot to grab, we're not going to grab it. And if they have a large established area of infarct already, taking that clot out, it's not going to prevent that large stroke. Some considerations, advanced imaging. If that patient had a CTA prior to coming into the hospital, say they're in a small rural hospital, had their CTA, we saw the clot and bringing them in. That's helpful to rule out. So when they arrive at a thrombectomy capable center, they can go straight to thrombectomy. And again, core infarct and penumbra sizes, that how much of the brain's damaged, how much is going to be damaged, and then physician's direction on that. The picture here is getting to be a little dated too, but some of the catheters used, it feels like kind of iPhone. Every year there's a new and better catheter retriever, etc. So there's all sorts of tools that provider can use to take that clot out of the brain. So my warning, there's a clot coming. Close your eyes if you don't like clots and watch it if you're a nerd like me. This is a patient that came in. The thrombectomy procedure is done on a biplane. Can be done on a singular plane, but biplane I think is what most physicians are trained on. We use our IR procedure room, but many sites use this under the cath lab procedures. It can be a groin or radial puncture site. A lot of times, depending on which instrument we're using for thrombectomy. It's a grain site, just because some of the stent retrievers are a little bit larger to go through a radial site. But as research moves forward, radial is being used more and more. You can see in the upper left picture, this is during a thrombectomy, and the yellow arrow is pointing where that occlusion is. So you can see where the blood clot is because the artery ends there. And then the doctor pulled the clot out, run dye and make sure it's open and staying open. And then the bottom is the clot from this patient. And the bottom left is the MRI post procedure to see the impact of that stroke. There's certain scans post thrombectomy, post dual energy CTs are kind of cool. Newer to Sanford about 5 years ago. So when we do thrombectomy and then do a post-procedural CAT scan, it's really hard to tell how much of that dye is left over from CTAs and from the cerebral angio that they just underwent. So a dual energy would subtract the dye from that to really tell us, is there blood in that area of stroke where we just worked, and helps with determining what kind of blood thinner they'll be on post-procedural. So we talked about ischemic stroke a little bit, a blockage in the brain. Talk a little bit about TIA, or transient ischemic attack. This used to be known a lot as mini strokes. This is for when patients come in, they have symptoms and then they resolve. Symptoms lasting a short time. And short time, I use air quotes all the time on that. It used to say 24 hours or less. And it feels like we used to have a lot of TIAs back in the day when maybe MRI and CT wasn't as advanced as it is. Typically, if that clot is in there for too long, I've heard 60 minutes, 2 hours, more than that, it will cause some ischemic damage. So that would be a stroke. So TIAs typically are very short lasting before resolving. And MRI would be negative to diagnose TIA. And then those symptoms are a potential to return. So if the symptoms resolve, watch for them to return. Typically are most worse for the patient, they'd return within the first 24 or 48 hours. The workup can be inpatient versus stroke clinic, depending on facilities protocols. ABCD squared score is a really good score to show how risky it is that those symptoms will come back. And should we admit this patient, or should we do an outpatient workup? So the criteria is off to the right here: what their age is, what their blood pressure is running, what their features of that stroke, what their symptoms were before they resolved, and how long it took. How long those symptoms persisted before they resolved, and if that patient has a diabetic history. So it gives you a score based on that. The higher the score, the higher the risk they are to have another TIA or full-blown stroke. Stroke mimics. So again, neuro is grayer than maybe our cardiac world. So sometimes we have stroke mimics. The number one mimic of stroke is hypoglycemia. So when we're talking blood sugar, what's this patient blood sugar? Why we check it is because hypoglycemia can mimic stroke. If that patient may start hypoglycemic and then we treat the blood sugar and it's normal glycemic and still having symptoms of stroke, we should still treat that patient as a stroke patient. Migraines. Seizures. So a seizure activity can cause what's called Todd's paralysis. So maybe an unwitnessed seizure, and that patient's brain shuts down around that seizure, causing paralysis, and they're found with paralysis. Can be a mimic of stroke. Psych and panic attacks can mimic stroke symptoms, and the rest of them kind of are caught best with the CT. So a subdural hematoma, bleeding on the outside of the brain, a tumor, maybe a fast growing tumor, syncope, and maybe blood flow is not getting to that brain, and that small cutoff can cause stroke symptoms. Cardiac difficulty, blood's not getting to the brain like it should from the heart, encephalopathy. So some of these stroke mimics, I feel like the minion sometimes that, oh my gosh, what? The this looked like a stroke when it was coming in. We kind of run in a stroke world that stroke is a priority. You can't go back and treat a stroke in the future if you think, oh, this is probably psych. I can't treat this as a stroke. You can't go back and treat it if you do an MRI and find it is a stroke. You can't treat it later. So we say stroke's a priority. It's an emergency. We rule out everything we can. But we do have, as all stroke centers will admit to, we do have TNK or thrombolytics that we've treated stroke mimics with. All aggressive centers will. Treating strokes with thrombolytics, you do have a risk of bleeding with that. So we want to watch that risk of bleeding at 6% or less. If we treat mimic, that risk is much less, 1 in 200 instead of 1 in 6 or 6%. And then I saw a quote somewhere that said approximately 7% of strokes can be a stroke mimic. So very common. And I have a case study. I love to learn from case studies. And this is getting to be a little bit of an old one, so I apologize about that, but that's how I learn the best. So a stroke mimic or a stroke chameleon. This is from 2023. We had a 73-year-old male. He came to an outlying rural community outside of Sioux Falls. New to the area, he had just moved from somewhere south, very south. Had a history of a recent DVT. He was on Coumadin, wasn't super compliant with this Coumadin at that time. His INR was 1. At 10:10 that morning, had a very significant left facial droop, left and arm severe weakness, almost plegic, and did a telestroke video with one of our neurologists. The neurologist saw him, and at the time he said, oh, my large vessel occlusion, or my buzzwords are up there. This guy looks like a large vessel occlusion, a great witness onset. They gave him TNK, or it might have been all the place at that time. I might be misspeaking. He was flown in and then deteriorated in flight. So his Glasgow coma went down to an 8. Minutes later, no cough, no gag, so intubated. And knowing that he deteriorated, and we had given tenecteplase, repeat CT of the head for bleeding, which was negative. So they took off, flew him to Sioux Falls, arrived in Sioux Falls, still thinking this is a large vessel occlusion. Based on his symptoms, he's getting worse. Did CTAs of his head and neck on arrival, and they were negative for large vessel occlusion, which had our physician thinking, maybe the clot dissolved, that lytics work magic, that clot probably dissolved, because he was definitely a large vessel occlusion on exam. Admitted him into the stroke unit, did an MRI later that night, completely negative. And that really got our doctor scratching his head thinking, well, he's extubated, he's still flaccid, he looks like a stroke. And then found out more to his story. His wife was not with him at the time. He was staying with his family. He was new to this rural Minnesota area, and he had a history of post-traumatic stress disorder, and he had episodes of left-sided weakness very often in the southern state he was from. I can't remember where he was from, to the point where they'd be flaccid. His final diagnosis was conversion disorder. He was discharged to a rehab center and eventually got that strength back, but still had these episodes several times since. So a very big chameleon of stroke, which was a big learning experience for us. So let's switch gears a little bit and talk about hemorrhagic stroke. Again, with the BFAST stroke presentation, again, we don't know if it's hemorrhagic versus ischemic until we do the CT scan, but using those BFAST acronyms to catch symptoms of stroke, best practice. But as a stroke nerd, I think I'm a stroke detective. I don't know, maybe not a very good one, but I'm looking at the symptoms, and I like to try to predict, is this going to be a hemorrhage or not? There are some symptoms within hemorrhagic stroke that can be common. Headache is more common in hemorrhagic stroke than ischemic. Sometimes they call it a thunderclap headache, an immediate 10 out of 10 headache, all of a sudden, the worst headache of my life, can be also accompanied by photophobia. Focal neurodeficits, so any of those BFAST deficits, can seize with blood in the brain. Usually decreased level of consciousness in comparison with ischemic stroke. Nausea, vomiting can accompany that altered mental status. Extreme hypertension. Any stroke can be hypertensive, but those scary 250s over 150 numbers come in with large bleeds. And then a potential for an unstable airway with those patients. It feels like hemorrhagic strokes change so fast that airway can become unstable quickly. So what is it? Again, a bleeding within the brain, and it's divided down to what type of hemorrhagic stroke depending on where that blood is in the brain. So there can be intracranial hemorrhage, blood anywhere in the brain, within the brain, intraventricular in the ventricles, subarachnoid within the subarachnoid space, etc. So blood on the CT scan, and then we'll figure out what type of, where that blood is to determine what type of stroke it is. When we're talking about subarachnoid hemorrhage, we always look for those aneurysms as a cause. So a case study that will lead us into our next review, 65-year-old male, typical history, uncontrolled hypertension. He is a smoker. He was having dinner with his family, suddenly developed right-sided weakness, became lethargic and vomiting. Brought to the emergency department, that's super high blood pressure, 210 over 110, and a CT is on the left here. So the white is blood on the brain. I work with Dr. Abdelazim, who is like my soulmate in another world. He's super A, B, C, D, OCD. And he said there's 9 critical steps with the bleed. And I like to talk about those 9 critical steps, knowing I'm not going to remember all 9 of them and they work in conjunction. So I'm going to reference his 9 critical steps to hemorrhagic stroke here. Step 1 and 2, controlling blood, step 1 and 2, so you can combine them together, controlling blood pressure and getting CTA imaging. So we have a plain head CT showing that blood on the brain. Old dogs like me, when we used to have a stroke code and we did CTAs on all of our stroke codes, when we saw the blood, we would stop doing the CTA. But it's actually better to complete the CTA to show how that bleeding is occurring. CTA imaging of those vessels will determine a spot sign. A spot sign is used to assess for continual bleeding. So you can see the picture on the left, that tiny little dot within the not so bright white is a spot sign. So that that bleeding is continuing, and we definitely need to get that bleeding to stop. If blood pressure is 140 to 160, and newer literature saying 130 to 150, and I apologize, I didn't update my slide. And that's a goal for this when we see that blood, to drive that blood pressure down to our goal. If blood pressure is less than 160 and no spot sign, it will show accumulation of blood within the hematoma. Spot sign significant shows active bleeding within that. So if there's no spot sign, hopefully the bleeding has stopped. If there's a spot sign, bleeding will potentially continue. So we have to be more aggressive, systolic blood pressure 140 or less. Our goal is, again, smooth, sustained blood pressure control, no peaks and valleys. Better blood pressure control early on is better outcomes for the patients. Step 1 and 2, blood pressure control, get a CTA typically, if this patient's in a rural center, you'd send them to a stroke center, and CTAs can be done there, or whatever protocol your facility uses. Step 3, reversal of blood thinning agents. Is this patient on blood thinners? Are they on Coumadin, Xarelto, Eliquis, Savesa? What do we use to reverse it? PCC? Are they on Pradaxa? Do we have Praxabind? Are they on aspirin, Plavix, Effient, Brilinta? If they are and we have that spot sign, we will likely reverse them. DDAVP, etc. Consider platelets. Did we give tenecteplase and then they bled, and then reversing? I don't have a red star on this, but I should. Best practice is when this patient is in and looking sick and all hands are on deck, maintaining his airway, and it's recommended to reverse, not having to look up what that reversal is for what drug. So ASA has an awesome chart of reference. What are they on? What do we reverse? And what is the dosing for that reversal, to have somewhere on hand? Again, printouts in your order system within your EMR, orders with this, and then an easy reference for physicians. Step 4, this can be done if you're in a small rural facility in a stroke center, trying to figure out what caused that bleeding, review for vascular pathology or a mass underneath. and management of ICH and prevention of herniation. Look at those ABCs. Of course, if that patient has an unstable airway, we would take care of that first. Elevating the bed 30 degrees. Historically, not corticosteroids and osmolar therapy used. There's no benefit, no harm within the recent recommendations. And then early neurosurgical consults. Do we need to evacuate this blood? Is there hemicraniectomy, et cetera, in the future? Neurosurgery also has an awesome chart in recommendations, when to place an EVD, when to evacuate, et cetera. So that's good to have on hand. There's a lot of trials going on about, when we're talking about penumbra of ischemic stroke. When do we do hemicraniectomy to prevent herniation? How much blood is in there? Is enough blood, too much blood, etc. Evacuation timing is another research trial too. So this patient to the left here had a hemicraniectomy. The white is the blood on the brain. The arrows pointing to skull. So typically our skull goes all the way around their brain, but the yellow and the red is indicating that that part of the skull was removed to prevent herniation. And then serial CT scans. Once they're in a stroke center, we want to make sure after 6 hours, we do what's called a stability scan, looking at that bleeding. Has it stabilized? Was there a spot sign? And we're re-imaging, watching for it to get bigger, etc. So serial CTs to watch what that blood looks like. Step 8 can be used back with step 1 and 2. Seizure prevention is not indicated unless that seizure patient is seizing. And then looking at a cause of that bleeding, hemorrhagic stroke. Do they have a history of hypertension? We're seeing, unfortunately, more and more drug use in the United States. South Dakota's no other now. Stimulants, cocaine, amphetamines, heroin can cause bleeding. So doing a drug screen on these patients. And one other kind of side note and best practice maybe that we've seen in Sioux Falls is, I'm an old fuddy-duddy, and I think, young people, of course, drug screen them. We've been seeing that age go up and up with those drug screens too. So it's not uncommon to drug screen somebody who's a little bit older than my head with stroke. And then an MRI down their stay to rule out any underlying pathology. So typical, most common cause of that hemorrhagic stroke is hypertension. You'd see bleeding in the basal ganglia, brainstem, cerebellum. And we'll talk about, I think the next slide, I have a couple of these common too. Cerebral amyloid angiopathy, CAA. The picture on the left, I didn't have a good picture in my files. This is a severe case of CAA. Those little dots all over the brain are little micro bleeds that can cause a bigger bleed. Becoming a little bit less of a zebra, seeing CAA as a cause of hemorrhagic stroke. All right, how am I doing on time? I have some case studies. If I have a couple minutes, maybe I'll run through them really quick. Do you think that's okay? Yes. Perfect. And again, this is how I learn the best. I relate it to a patient and then it stays with me. And again, clots are icky. There are some clots in here, but I'll go over a TNK, a thrombectomy, a dual treatment, giving TNK plus thrombectomy, and a young stroke. So with any patient that comes in and receives TNK, tenecteplase, we want that door to needle to be low, definitely under 60 minutes. If they're above that, it's a case review for us. So we look at that very closely. We get a TNK of 90 minutes, which is way past our goal. And I have the approval. This is a Dr. Sandu patient, and he said, yeah, give him my name. I was baffled by this case. So a stroke zebra is what we'll review. 70-year-old male. He was kind of a unique male, kind of a grumpy 70-year-old, presenting complaint, I have an eye problem, is what he told our triage. He came in through triage, ambulatory through triage. And he wouldn't say, it's not painful. He wouldn't go on, what is your eye problem? That's what I have. He wouldn't elaborate. Brought him back into triage and then found out more about his case. He had abrupt onset of bilateral vision loss, complete vision loss, seeing all black, no lights, no color, no motion. He was watching TV when it happened. I can't remember what program, but it started at 2 o'clock because that program was starting at that time. He arrived at the emergency department at 14:33, and it makes my skin crawl via private vehicle. He drove himself with this eye problem. And then we found out what the problem was and activated the stroke code. So 20 minutes after arrival. CTAs began shortly after 15:02. CTA of head and neck, no large vessel occlusion, but showed some scattered soft plaque. So still Dr. Sandu was on at this time, said, you know, that his vision loss pattern is strange. I don't know what's going on, but it doesn't sound like a stroke to a stroke specialist. Started an MRI at 15:38. And then his MRI is not perfect because he was wiggling, but you can see in the bottom, there's 2 light patches almost matching in the occipital area. So he's having bilateral occipital strokes. Dr. Sandu's watching the MRI as it's happening. He's like, oh my gosh, he won the unlucky lottery. He's having 2 identical strokes in his vision sites, vision fields. So that's why he's having this complete blindness. Ordered TNK, gave it, and then did see some improvement on this gentleman. But he said, oh, that's my 90-minute needle because I wasn't expecting an unlucky stroke in the bilateral hemispheres. Another case study, a 74-year-old, he presented to an outlying critical access hospital. He was driving by himself with, came in as a John Doe, didn't know his name, didn't know what was going on. Found on the side of the road at 10:15, slumped over in his car, unsure of last known well or the onset, and he could not confirm he was globally aphasic. One of his, I thought, kind of cute connections was he had cinnamon rolls in his front seat and they were still warm. Like the EMS provider touched them and it was still warm, that he'd picked him up somewhere. And he also had a bottle of open aspirin that were scattered all over the car. So kind of strange. Picked him up, brought him into this critical access hospital. He had global aphasia, so could not speak and also couldn't understand. He had left gaze preference, so eyes gazed off to the left, and right-sided severe weakness. NIHSS was a 12. CTAs completed in an outlying facility showed a left MCA M2 occlusion, so large vessel occlusion. Brought in, doctor says, you know, I still, knowing that these cinnamon rolls were warm, he probably wasn't driving for too long, etc. I still could not give TNK because I'm unsure of the onset, but my gut is telling me it's pretty soon to when he pulled over his car, but we could not confirm that. So we did not give him TNK. He arrived here, had a groin puncture right away on arrival. The arrow is pointing to where that occlusion was, and he had a big long clot to pull out, achy clot off to the right. Admitted, he was a little bit sleepy after thrombectomy, but conjugated gaze. He was looking around the room, able to verbalize he was having aphasia. Strength improved. He was able to follow with his right. The next morning, I always say neuro changes happen during rounds or during shift change. During neuro rounds, he became obtunded, not following nonverbal. So when we're looking at his assessment on rounds, he now has a right gaze. So when we remember a stroke, you look at your stroke. So his left eyes were, he's having a left hemispheric stroke. His eyes were gazed to the left before thrombectomy, and now they're gazed to the right, saying he's likely having seizures. That's what's causing the obtunding. And he actually was. He had a seizure history. Finding out more about his story too, I always think there's little details that make these patients worth remembering. He was a locum physician in one of the rural areas. That's why his aspirin was all over his car, that he popped a bottle of aspirin, couldn't get it, and it went everywhere. He was trying to take his aspirin knowing he was having a stroke, and had a history of seizures. So the stroke induced a seizure. In that temporal area, you can see that MRI off to the left. Dual treatment. So you can ultimately give thrombolytics and have a thrombectomy if that patient's within the thrombolytic window and a large vessel occlusion. Dual treatment. This is a cool case, a 47-year-old female. She's from Sioux Falls. She was out shopping at Walmart on the north side of town, had a ground level fall due to weakness. Called 911, the Walmart store, called 911 right away, presented with EMS. Onset of 13:45, was able to arrive 14:22. Some prior medical history of tobacco use. Otherwise pretty negative for a 47-year-old. She came in that right-sided weakness, arm and leg, severe neglect, right facial droop. NIH was 20 at that time. A quick door to needle, 16-minute door to needle, and then CTAs revealing a left M1 occlusion, so definitely a large vessel occlusion. Received tenecteplase and then transferred to IR for thrombectomy. And it's hard to see on this black, but this is an AI image of this patient's case. You can see the red is less than 45% blood flow. And you can see the cutoff within that red where that vessel should be showing up, but that's where the clot's sitting. So I'm, again, a big stroke nerd, so I like to break down the times. Onset 13:45, arrival at the facility 14:22. Tenecteplase door to needle was 16 minutes, but even bigger than that, 53 minutes from onset. EMS really worked to get her in. Pre-notification helps with that door to needle, etc. But 53 minutes from onset when that stroke started is amazing for this patient. Groin puncture within 32 minutes of arrival. Recanalization, so when they pull the clot out and run the dye and make sure everything's all open and clear, was 48 minutes after arrival, so a quick thrombectomy case. Up on the top left, you can see her thrombectomy images where there's a cutoff, full flow, and then the clot pulled out. So icky clot, I apologize. Interesting on her MRI was negative. That clot was pulled out so soon. It was within an hour that her MRI was negative. So she could technically be a stroke aborted with stroke therapy or even a TIA. NIH was 0, shortly able to go home. So 47-year-old, very lucky lady. And then this was just a surprising case for me, so I thought I'd add it on there too, because I'm getting older and I'm not expecting young people to have strokes. So this is a young stroke, 18-year-old student at South Dakota State University. He was having 1 week of headache with some dizziness. This must have been a September case. I have the dates in there. Complaints a good headache. Then a week later, when he came to the emergency department, he told his mom, "I'm not feeling well." Mom brought him to the emergency department in Brookings, South Dakota. Complaints of a headache, but not bad. It's way better than it was. It's a 1 out of 10 now. So it improved over the last couple of days. He had some nausea, vomiting, kind of off and on, getting much better since his headache was getting better. He was given a migraine cocktail at an acute care. And then within the Brookings Emergency Department, they took the CT scan and like, oh, something's not quite right with this young man. Sent him on down to Sioux Falls, and they showed this large right cerebellar infarct, which is crazy for an 18-year-old who was healthy. CT angio of head and neck and negative. And doing a stroke workup on an 18-year-old, echo TEE showing a PFO, so a patent formin ovale within his heart, potentially causing a clot that went to the brain, and some hypercoag testing. So you can see the cerebellum on him, a pretty decent size cerebellar stroke for an 18-year-old. I should have said in my disclosures, I talk too much and too fast, and I didn't include a question slide here, but questions, or did I explain anything, or any questions out there? I'm definitely open. I can stop sharing too.
Yeah, Jessie, a question did come in. Let me read it for you. It says, for TIA whose symptoms resolved and then returned, what would you use for last known well? Onset of initial symptoms or time they returned?
If they truly resolved and the NIH was 0 with no symptoms, we would use when the symptoms restarted. So maybe they completely resolved at 10 o'clock, came back at 2 o'clock, we'd use that 2 o'clock as an onset. Good question.
Yeah. And then you're getting some kudos over here in the chat from Morgan. She said, great job.
Thank you, Morgan.
Yes, Jessie, this was a fantastic presentation. So comprehensive and thorough. I love your case reviews. Sharon Jacobson, she has her hand raised. Do you have a question? I should have researched a little more. Do I need to take someone off mute to ask a question, or can they only type them in?
And
Let's
I
see.
apologize too, because I didn't leave much time for questions. So that's my bad too. I apologize.
See here. See if I can. Sharon, if you have a question, I'm going to hit that you can come off mute.
Sorry,
Can
can you
she?
hear me?
Yep, I
It
can
was an
hear you.
accident. I apologize. I accidentally hit it, so I have no,
Oh,
but I
that's
will
all
say
right.
this was a great presentation.
Thank you, Sharon. She was just waving.
Yeah,
Very, yeah, it
but
was
then
very
it
good.
made me learn how to take someone off mute. So thank you.
No problem. Anytime.
All right. Okay, well, thank you so much, Jessie. This was fantastic. We have this recorded, and once I get the link made, I will send it to everyone who registered, and we'll have it also just available on our Mission Lifeline Stroke website, which is actfastsd.com. So I will send that out as well. You can join us next week. We'll be doing one next Friday, and I believe that one will be a rehab presentation. It's the same link for registration. So if you registered for this one, you're automatically registered for the next one. And I just want to point out that it's this is a system of care project. So this is a great opportunity to learn what the other parts of that stroke system of care are. So knowing that EMS and hospital really do impact that rehab state would just be important for those of you that haven't had an opportunity to learn much about stroke rehab to see that part of the team and hear what they do. So thank you all so much. Have a wonderful afternoon and happy Nurses Week.